starting to look, oh, thank you, Amy. It's starting to look like a nice, nice full meeting room. So thank you everyone for being, oh, hi, Chelsea. Oh, and John, hi, John. All right, let me do roll call. And then as always, if people come in after we do roll call, then we will fully recognize them as participants of this meeting. Good morning, everyone. My name is Laura Reichart. I'm the director of the Hawaii State Center for Nursing. I am also the chairperson of the study. This is the working group to study the feasibility and impact of the state adopting the Nurse Licensure Compact. Today is October 2nd. This is our second to last meeting. Our last meeting will be on October 16th. So in 2 weeks.
Sorry, Tuesday, October 17th.
Oh, sorry, Tuesday, October 17th. I knew I was going to say the wrong date. Tuesday, October 17th. It will be on a Tuesday instead of a Monday, so please correct your calendars if you still have it on a Monday. And then we will go into report writing after that time, which will be iterative. It'll be a process that we will share amongst the working group members. So the Center for Nursing will provide drafts for your review. I'm going to do a roll call for our assigned members of the working group member. If your name is not part of the roll call, please note that you are then a guest. And so when we do have questions and answer, the question and answer period, please reserve the time for our working group members to ask questions first. And then if time allows, then we will allow other people to ask questions. Please also note that if you are on the agenda, thank you for being here, and we will call your name throughout the agenda. But I've noted that we have everybody here for that. So thank you very much. At this time, we will do the working group roll call. First is myself, Laura Reichart, present. Next is Director Ondo from the Department of Commerce and Consumer Affairs, or delegate. And I believe we have Rico and the Board of Nursing, who are representing DCCA as well. Thank you. Next, we have Rena Chung from the RICO division of the DCCA.
Yes, good morning, and please excuse Esther Brown, who was unable to attend today.
Yes,
thank you.
Okay, and then we have for the Board of Nursing, we have both Leanne Tashima and Chelsea Fukunaga. Good morning.
Morning.
Good morning.
From, Senator Kehokalole or representative? Excused. Then we have Senator San Buenaventura, and I saw Anna Matsunaga join us.
Hi, Laura, it's Anna. And
Hi,
Senator San Buenaventura is going to be kind of late, but she'll be here.
Okay, great. We will note her. Thank you so much for letting me know. And is Amelia joining us?
Not today, just me.
Not today. Okay. And then from Representative Bilatti's office, I saw Tom.
Yes, good morning, Laura. Both Tom and Hector Venegas joining in today. I'm hoping to see Rep Bilatti, but I haven't spoken with her this morning, so hopefully she'll join in.
Okay, and she had confirmed, but we'll keep an eye out for her, and we are grateful for your presence.
Thank you.
And then next we have Representative Nakashima, who is here bright and early with us. Good morning, Rep.
Good morning.
Next on our list, we have Paige, representing Healthcare Association of Hawaii. Oh, and I see Director Ondo. We are letting her into the room now, so she's present. I don't see Paige yet. We will look out for her. Next, we have Jesse Sleva from HGEA is unavailable today, so he is excused. Then we have the representative from the Hawaii Association of Health Plans, and I see Don. Good morning. And then I also want to recognize that we do have Paula Arcena, who is also part of that organization, but represented on the agenda today. We don't have John. Paula, since I'm on this call, could you text John and make sure that he's going to be coming on? If that's, could I delegate that to you to make sure that, or Rain Soriano is the person who is going to be present. And then for the American Nurses Association Hawaii chapter, I saw BJ join us. There you are, BJ.
Morning, everybody. Yep, BJ
nice to
from
meet you.
Hawaii ANA. Morning.
Thank you so much. And then staff from the Hawaii State Center for Nursing, Amy Ono, and then again myself. And then everybody else, please, thank you so much for being present with us. We will, as I mentioned, the people that I called by name today are working group members. Please reserve the time for their questions first when we have those Q&A sections. Because it is a very full agenda, we're going to ask that you hold your questions until the Q&A sections. Sometimes we can have an iterative conversation, and today if you can hold your questions until those scheduled break times. And then everyone else, when you have those questions, we will attend to those as time allows. And then at this time, I'd like to move on to the second item of the agenda, which is to review and approve the minutes from the last meeting. They should have, for working group members, they should have been sent to you. And if we can have any comments, and if there are no comments, then a motion to approve. I think Leanne nodded her head yes, so I will take that as a motion to approve. No, does anybody have any comments or corrections?
No comments. This is BJ from Hawaii ANA. I move to approve.
Thank you, BJ. And if there are no other comments, we'll take that as we'll put those on the record. Moving on, we are now moving towards the content section of the agenda. I just want to say I try to kind of give everybody an idea of what the theme is for these meetings. So today's thing, we want to kind of wrap up some of the open-ended questions that we had for our state, kind of like how we're functioning. And so the Nurse License Compact, we are not just thinking about the Nurse License Compact, but we have to compare it into how our state is functioning overall in terms of licensing and license processing. So we're inviting DCCA Board of Nursing to provide updates about a lot of logistical questions about the licensing processing time. And then we're going to ask some other questions that were in the resolution about differences in renewal, particularly with continuing competency, and then the jurisdiction and regulatory oversight of nurses in the state and any other matters. So kind of like other kind of errata that the Board of Nursing may have to present. So at this time, I am going to start presenting, and then Leanne and Chelsea, I'm going to give you the floor.
Thank you. Good morning. Can everyone hear me? Hope so. Okay. Thank you for letting us do this presentation. My name is Leanne Tashima. I'm the Executive Officer for the Board of Nursing. Also on this Zoom meeting is Chelsea Fukunaga, who is also assigned to the Board of Nursing. Next slide, please. So just as a background information, the Board of Nursing is established pursuant to 26H, Section 2 under the Hawaii Regulatory Licensing Reform Act. I've highlighted the sections regarding why the legislator adopts certain, the regulation of certain professions and vocations. And you can look at number 1, the regulation and licensing of professions and vocations shall be undertaken only where reasonably necessary to protect the health, safety, or welfare of consumers of the services. The purpose of regulation shall be the protection of the public welfare and not that of the regulated profession or vocation. And then number 2, regulation in the form of full licensure or other restrictions on certain professions or vocations shall be retained or adopted when the health, safety, or welfare of the consumer may be jeopardized by the nature of the service offered by the provider. Next slide, please. So then you have the Board of Nursing. Oh, sorry, that's more stuff on 26H, but you can read that later. And you can forward my slide to anyone who requests it later, the PowerPoint. Okay, so the Board of Nursing, oh, I think you have to go back one. Yeah, there. So, oh no, is there a slide missing. Oh, no, I'm sorry. You're right. Next slide. Sorry. So under the Board of Nursing, the board falls under the Department of Commerce and Consumer Affairs. The division that is assigned to where the board falls under is the Professional and Vocational Licensing Division. PVL, also known as PVL, oversees 26 boards and 28 programs. We consist of a central licensing branch, an exam branch, executive officers, secretaries, and our administration. Our licensing branch consists of both an application section and a record section. They process all the applications for 26 boards and 28 programs. So, you know, that's not just what 54 areas. Each area may have multiple applications, including nursing, which has LPNs, RNs, and APRNs. Okay, next slide, please. The purpose of the Board of Nursing, as stated in their Practice Act, Chapter 457, is to safeguard life and health. Any person practicing or offering to practice as an APRN, a registered nurse, or a licensed practical nurse in the state for compensation shall be required to submit evidence that the person is qualified to do so. Okay, so basically what the board does as part of their powers and duties is to establish the minimum requirements for an individual to practice in this state with a minimum competency level, i.e. education, exam, etc. Next slide, please. Sorry, I'm trying to run through this so you guys have time for questions and answers. If you have any questions or comments, you can jot them down and then, you know, we can respond to them after the presentation. Our licensing branch, again, they process applications for all professions licensed under the PVL. Currently, applications can be mailed in or filed online. Nursing is the largest licensing area and is assigned 5 office assistants. Most areas are assigned only 1 office assistant. We have 2 office assistants to process exam applications and 3 for endorsement applications. Next slide, please. Okay, now we get into the nitty-gritty numbers. This is the nursing application average processing times for 2021. I'm sorry, I didn't, couldn't go back sooner. When we switched to our new system, database system, we were able to capture this data. We're still working on seeing if we can see anything prior to 2021 or during COVID. Okay, so you see the month, you see the average process times for all phases. Okay, so this is the average time. These phases refer to once an application is received, it's either reviewed and they're sent a deficiency letter, they're approved to sit for the exam, or they're licensed. Okay, those are the basic phases. So if you look in February of 2021, the average processing time was 123 days. March was 116, et cetera, et cetera, et cetera. If you look down all the way to December of 2021, it was cut in half, basically. Okay, the next slide, please. So this is the numbers for 2022. As you can see, we were trying to average 2 months, but I wanted to point out something else that was just emailed to me this morning. So okay, I'll get to that in the 2023 numbers. But as you can see, we considerably cut down on our processing times. Now, I'm not saying that these numbers reflect the issuance of a license. We receive a lot of deficiencies. Okay, they fail to either do their fingerprinting, or if they do their fingerprinting, they fail to put in the field print code, so we are unable to retrieve their fingerprint results. Information on their application, their license in these states, but it doesn't match up with their nurse's license verification report. Just their NPDB, which is the National Practitioners Data Bank self-query report, is not quote certified. They just copied it from somewhere and we don't take copies. So a majority of these applications, the average processing time may reflect deficient applications and not when the license was issued. Okay. Next slide, please. So for 2023, these are the numbers that we have so far. Again, same thing regarding the average processing time. These probably majority of these reflect deficient applications. Yeah, so we are working on clarifying our, if you ever looked at our instructions, it's just horrible. Okay, we're just slapping things at the last minute onto the application. So we're in the process of amending that and clarifying it so it's not 10,000 pages, but it's a reasonable maybe 2 or 3 pages. Okay, next slide, please. So administrative initiatives. As I mentioned, we are in the process of amending our application instructions as well as the application itself. We are working on a new online submittal. So currently an applicant can file online. This is a different online process that allows the applicant to upload a lot of documents. If they have a yes answer for a prior conviction, they can upload their documents, their signed statement. If they can upload their NPDB self-query report. The only thing we would still have to do is once it's filed online is check that they did complete their fingerprint and that we can retrieve it and also retrieve their NLC report. So if you look at the online process, and you will be able to view it hopefully sometime in the next couple of weeks when we go live. When someone applies online, they have to indicate that they have already done their fingerprinting. If they put a date that, oh, I have an appointment tomorrow, but I'm going to file my application online, it's going to get rejected. Okay. So a lot of things are meant to have the applicant already complete the requirements so that when the office assistant in our licensing branch reviews it, they can easily do it. Look at that application that day, right? Hopefully process it in a more timely manner if it's complete. Any deficiencies, again, will delay processing. Okay. So we're hoping that this goes live in a couple of weeks. They're still doing testing and trying to work out last minute glitches, but we're shooting for the next couple of weeks. Okay, next slide, please. The other initiative, as you know, there was a Senate Bill 63, that was the last one, going through this past legislative session that would allow the board to issue a temporary permit for 6 months to any out-of-state nurse wishing to practice in the state temporarily. That bill didn't go through. It died in conference, basically. So what we had to do was, we were asked to check if this could be done in our administrative rules. We did check, and it appears that we could put it in our administrative rules. So we've already started that process. As you know, amending any administrative rules is a timely process. We're hoping to get it done, if not by the end of the year, in the beginning of next year sometime. Right now, we're on step 3 of 20,000 steps, but I'm trying to push it through as fast as we can. So this proposed temporary permits is similar to Senate Bill 63, which would allow an out-of-state nurse who has a current and unencumbered license in another state to apply for this temporary permit. All they have to do is order a NLC verification so we can make sure that they're currently licensed in another state and that no license is encumbered in any other state. The language also allows a individual holding a multi-state license to apply. Instead of this temporary permit will be valid for 6 months and will be specifically tied to a healthcare entity that is licensed or falls under the Department of Health, Chapter 321, Section 1110. Okay. Yeah, so we're working on that. I provide updates to the board at their monthly meetings as to the status of these rules amendments. So we'll keep you posted. We can give you an update at your October 17 meeting. Okay, thank you. Next slide, please. So let me get into the Nurse Licensure Compact Uniform Licensure requirements for a multi-state license. So on the left, I've indicated what the Nurse Licensure Compact requirements are pursuant to previous materials that Laura had provided to the group. And then on the right-hand side is Hawaii requirements. Because Laura wanted to know, is there anything that we need to add to our license application requirements in order to, should the NLC, should the Hawaii join the NLC? So the first one is education, has to be educated, US educated or foreign educated. We also have requirements for what is a US educated applicant versus a foreign, and the same requirements, it appears as the NLC. So we're good on that one. For the exam, we do require the NCLEX as well. However, we also allow for the SBPTE, which was the exam prior to the NCLEX. So if we adopt the license requirements for the compact, those individuals will not be allowed to apply for a multi-state license. The next one is CBC. We already have that requirement, unencumbered license via license verification. That is also a current requirement. If I'm misreading it, I apologize, but according to the NLC requirements, the individual can't have any prior convictions or agreed disposition of a felony. Okay, Hawaii looks at all convictions, whether it's a misdemeanor, a felony, or what, and looks at it on a case-by-case basis. Okay, so they don't exclude just anyone with a felony conviction. They'll look at when it was, what it was for, what has the person, after they turned their life around, they went back to nursing school, they've been licensed for the last, I don't know how many years, that kind of thing. So they'll take into consideration all of those things. Excuse me. The next one is currently enrolled in an alternative program. We don't ask this question on our application. We don't have the authority to ask this question. If someone is has a board agreement with another board of nursing that they are enrolled in an alternative program for alcohol or other substance abuse, the board will also look at this on a case-by-case basis. And in some cases, if they are in a current program, Hawaii may issue a license. They don't have to. They may issue a license with the condition that they be in compliance with that alternative program. And the last thing would be a US Social Security number, which is, quote, required in order for us to issue a license. Next slide, please. Comparison for nurse renewal requirements. So Hawaii requires continuing competency, just not CEE, strictly a continuing competency requirement that consists of about a dozen learning activity options, one of them being continuing education. Other states, the following states do not require any continued competency to renew a nurse license. That would be Colorado, the Louisiana Practical Nursing Board, New York, and Wisconsin. According to the latest information, Colorado, Louisiana, and Wisconsin are all compact states. Only according to that, New York is also pending legislation to join the NLC. Yeah. Okay, next slide, please. So additions to the NLC model language by other states, as we all learned from previous meetings. So we can add, we can't change the language in the compact, but we can add enabling language. So here are examples that, based on what Laura had provided us previously, what other states have done to enable them to adopt the nurse licensure compact, which, as you can see, doesn't affect the requirements for licensure. So we can't change that. Okay. Next slide, please. So just discussion purposes, join the compact. Board's perspective, pros. This would allow nurses to move more freely between compact states, including Hawaii, and also allow Hawaii nurses more opportunities to practice in another compact state. Okay. Next slide, please. So I'm going to go over some of the cons. The biggest one being the fiscal impact. When we approached the National Council of State Boards of Nursing, the NCSBN, we asked them, once we started submitting our license data to nurses, they were able to see of those individuals that applied for a Hawaii single state license, how many of those already had a multi-state license in another state that would not have been required should we join the compact to apply for a nurse license. So they came up with over $1 million in loss of revenue based on that, those figures. In addition, if we have to join the compact, we would have to pay an additional annual membership fee of $6,000. Okay. The results of that would be an increase of license fees for single state licenses. So right now they pay upwards of $234 or something like that. It would definitely increase. And there may also be a reduction of board and licensing branch staff to process applications. So we will be back down to where we are in processing times. Next slide, please. Loss of autonomy. The compact language cannot be amended, no material deviations. States may only add language that is not a material deviation. And that's what I showed you earlier, the enabling language, confirming changes to existing law, employer requirements, workforce data reporting, and CE, etc. The results of this is the board or the legislature cannot make any changes to the license requirements, add or delete, should we feel necessary that it is required to protect the public. We will lose that autonomy. Okay, next slide, please. This is the last one, scope of practice. The scope of practice for LPNs and RNs may differ from state to state. What may be allowed in one state for an RN or an LPN may not be allowed in another state. This may jeopardize patient safety if the nurse, excuse me, holding a multi-state license in a state where a certain procedure is prohibited, and they come to Hawaii and they're asked to perform that procedure for which the nurse has not received any additional education and training. Some of them may ask, some of them may just attempt to do it. Okay, so that also puts the patient's safety at risk. Next is enforcement. You already heard Rico's presentation on their concerns regarding enforcement against any multi-state licensed nurse practicing in our state. Oh, sorry, one more con. Next slide, please. Tracking who is practicing in this state. The Nurse Licensure Compact does not allow any board to require an individual with a multi-state license to file an application with the Board of Nursing. So if someone holds a multi-state license in another state and they take a temporary assignment in Hawaii, we won't know. They are not required to file an application, and we can't require that. Okay, so we won't know who's practicing in this state. That would make the workforce data for the Center for Nursing hard, and they're going to have a hard time determining whether there are quote workforce issues, and we're going to have to rely on the healthcare entities or whoever to report that, but there won't be quote data. Are healthcare entities willing and able to provide a list of nurses working at their facility under the NLC? I know we've gone back and forth with this one, but should the nurse licensure compact bill move through, we will have to put a provision in there to have at least the facilities where they're working to keep track of this. They would have to report it. They can submit the information to the board or to the Center for Nursing or to the board, and we will forward to the Center for Nursing. The board, it would have to amend also, I'm sorry, the Department of Health law, because the board does not have jurisdiction over these healthcare entities. So sorry, didn't mean to pick on Chris, Queens. Sorry, Chris. If Queens fails to report monthly or whatever it is that they're required to report, the name, the address, the email, anything about a multi-state licensed nurse practicing under the compact, working at Queens, if they fail to report that, there's nothing we can do. Okay, we can't check if it's accurate or not, all of that stuff. So, why have a requirement if it's not enforceable? You have to keep that in mind. So yeah, 321 would have to be amended. So you'd have to get Department of Health to buy in on this as well. And then, like I said, the reporting, what and who to report to. I know in the past, the discussion was, well, report it to the board. Yeah, okay, I can see that now, and we'll pawn it off to the Center for Nursing. But again, we're not going to keep track. Hey, sorry, Chris again. Hey, Queens, you didn't submit your monthly report, that kind of thing. We don't have staff to monitor that. Okay. In conclusion, must all be happy I'm finished. All right. Next slide. Thank you. So joining the compact will allow more nurses to fill vacancies on a temporary basis, but at what expense based on the concerns raised? Complaints by healthcare entities that the license process is taking too long. Yes, that was the case. However, it appears that the processing times have dropped considerably, and there are initiatives that we are working on that would authorize the issuance of temporary permit and streamline the online application process. My last question to the group is, who else would benefit by joining the NLC? And that's my presentation. Thank you. Any questions? I'm going to defer to Chelsea.
And thank you. We have two questions that were or three questions. Two questions that are in the chat that I just want to recognize first. And then the two people who had the questions their hands are up. So the first question was related to the processing time. Are these business days or calendar days?
We normally go by business days. So we don't count days when the office assistants aren't working.
And then how is the processing time shortened was the other question put into chats.
Okay, so for your information, we had temporarily hired a whole bunch of temporary workers. They found some funding to have a handful of people come in and work and assist with the applications for nurses only. Okay, this may have had an impact on that. We believe it did. They came in, I want to say this year sometime. So if you look at my statistics, that would have been this year. But in 2022, we're already down to averaging around 60 something days. Yeah. So that probably had an impact on it. Can't say for sure. Maybe hardly anyone was applying. Who knows?
Great, Leanne. This is BJ from Hawaii, and that was my question. I think it's a testament to the fact that if we can strengthen the Board of Nursing, we can facilitate faster licensing renewal, et cetera. My other question had to do with, you had mentioned that the Model Nurse Practice Acts can't be changed once they're brought into a state. But does the National Council for State Boards of Nursing have some, I don't know, group or oversight committee? Because they
Yes.
must look at changes necessary for all of the NLC states, right?
Yes.
And would Hawaii have an opportunity to be part of that?
Yes.
Yes. Okay.
That would be a quote requirement. The board would have to select. It could be either the executive officer or it could be the chair of the board. They would have to attend these, they call them the NLC meetings, the Nurse Licensure Compact meetings. So there is a quote commission. That's why if you look at why Washington had to change their enabling language for them to join the compact, they were known as the Commission on Health Quality, blah, 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 whatever. They had to change the name of their board to the Washington Board of Nursing because it was too confusing with the NLC commission.
Got it.
So there is a commission made up of all the NLC members, and they meet, I want to say twice a year. I know for sure. I don't know if they meet other than that virtually. They are working on administrative rules, but they're not, to change the actual compact language that every one of those individuals, 41 states supposedly have adopted, and it was legislatively put into their statutes, is hard to change.
Yeah.
Because now you're asking 41 states to go
Takes
back
to
in
change.
and
Yeah.
make the change. So
Yeah.
that
yeah.
is pretty status quo. It's just the administrative rules, what they address. Just like
Got
Hawaii, right? You have your statutes and then you have your administrative rules to clarify. So
Got it.
we can probably get you what the draft looks like, what they're looking at changing or clarifying. So let me write
Great.
that down.
Thank you.
Okay.
It's really
And then-
helpful information. Thanks.
Yeah, and thank you for your questions, BJ. Paige, you had your hand up next.
And I think, thank you for answering the days question.
Oh,
I think
Paige, could you stand closer to your mic because you're a little garbled?
or can you hear me better?
Yes.
Okay. And thank you. And we'll ask Alani. Yeah, I remember she had brought up some of the numbers, and I was looking through my notebook, and it might be in a different notebook. So thank you for doing that. I had a couple questions, if that's okay. And I think the first would be just if you're able to, Leanne, talk about some of the online system and whether or not the online system is partially designed to help reduce the deficiencies in the applications, because I know that's something we've talked about, and that when applicants have the deficiencies, right, that does increase the amount of time for processing and for approval. And so I don't know if you're able to provide kind of any insight into that online application, what it might look like, how it might be helpful to Board of Nursing, and maybe even for the employers to be able to say, okay, this is just what you need to put in. And then I think Helene actually asked another question I have, but I also just want to get to Rain's question too, because I did have a question on, what the quality of care slide specifically, if you have specific examples. I think, some of the women's reproductive services, I think that was brought up in a previous meeting.
Okay,
but if you have any
Paige,
other examples.
Paige, I can only listen to one question at a time.
Oh, sorry.
So can I do the first
trying to be
question and then you
efficient.
ask your second question? Sorry,
Yeah. Is that okay, Laura?
I can't multitask.
Okay. All
So-
right. So
See, look, I forgot what your
Rain
first
and
question was.
Helene asked them.
Oh, I'm sorry. So your first question was in regard to the upcoming streamlined process to file online? Okay,
Yes, any
so-
details?
Yep. Okay. So as I indicated, to cut down on the deficiencies, the applicant, when they create their MyPVL account and start going through the process, they're going to have to click on, I read the instructions and requirements, which we have cut down considerably to include only the major things that they really need to know, but the important things that they really need to know. They are going to have to click on, I acknowledge that I read that before moving on. So there's going to be a lot of acknowledging by the applicant before they can move on. As I indicated earlier, in regards to the fingerprinting, the criminal background check, right? So they're going to have to read that little blurb and click on acknowledge, and also indicate a date that they went to get fingerprinted. If that fingerprinting date is after the date that they're filing their application online, they're not going to be able to move forward. Okay, so that allows one assurance that the applicant has completed that requirement. So when once it's submitted, the office assistant can go online and check. Okay. The other thing is to upload the National Practitioners Data Bank. That has to be something they already have, right? The other thing is the nurse's license verification. Same thing with the criminal background check. You have to indicate that you have already ordered that and that it's available. Okay. Any yes answers, prior convictions, prior disciplinary action, they have to be prepared to upload any of those documents. It is really baffling to me how people will apply for a license, answer yes to a question, and not submit any documents. Okay. The instructions are very clear. What we need, we can't just, oh yeah, you had a prior conviction, so it's okay. You don't have to provide any information. No. So, it's not the board's fault for not processing these applications.
Right.
And I don't have a number I can provide to you, but it's the number of deficient applications that are delaying processing, because our office assistant has to take the time to write a deficiency letter and email it to them. Okay, so if we can cut down on those kinds of deficiencies, yes, it would probably streamline the process a lot better. Okay, so those things
those
already, go ahead.
And I was just going to say, those are probably the biggest deficiencies that you see in the applications.
Yep.
I think what you're intimating. Okay,
Yep.
that makes sense.
So the applicant has to be prepared to have all that information so that they can upload all that information and it'll streamline the process. If they're not, and this goes for endorsement and exam applicants. Okay, so if they're not prepared and they just got an assignment sorry, Chris, Chris Clark, I'm so sorry, at Queens, and I start in 2 weeks. Oh, shoots. Okay. They have to be prepared to upload all of that information and make sure that they met all the requirements. We're not waiving any requirements. We're just making it easier for them to upload the information so it can be processed and reviewed faster. Does that help?
Yeah.
Okay.
Do you know what the processing time usually is for applications that don't have deficiencies? Because it's much shorter, right? I mean, I think we've talked about that.
Yes.
And while Leanne's looking up that number, I looked at the first number of the license number of this calendar year and then through August. And there were 3,838 licenses just in those 8 months. So that's just off of Board of Nursing minutes. That wouldn't be the renewals, that would be the new numbers. And that's an average of 480 new licenses a month. So I just want to put that into perspective. And again, drill down that people who have a license in Hawaii does not equal hands-on bodies, because we still have a workforce shortage, right? With 3,000 more people licensed in our state. So license portability just means that you have the availability to work in many places, but that doesn't mean your physical body is there. And that's where our problem really is that we don't have enough hands-on bodies. So I just want to reiterate that when we're thinking about processing time, it is very important. Processing time when we're thinking about our local workforce, probably the most important is new grads, and they will not be eligible for the nurse license compact. That's a different thing. The nurse license compact is for licensure by endorsement. So they would get a new license in Hawaii, and then maybe they could get that NLC for other states. But that is, so we have to think, you have to be able to think about the different categories and the different classes and the volumes and the nature, and be carrying all of those different pieces of information at the same time when we're determining our conclusions about this study. Sorry, Leanne, I'll let you talk again.
So I don't see in the information that was provided to me that is indicated. Again, it's an average processing time for all the phases, from the time it was submitted to the time they were issued a deficiency letter again, or approved to sit for the exam, or even licensed. So those numbers that I gave you is just an average of all of those different phases. So I don't have one that is specific to how long a complete application submitted, how long that processing time is.
Thank you. I think my only other question is, I think Alani, we're going to follow up with Alani on my question about the numbers, and then I just was piggybacking on Rain's question about, I think specifically the quality of care and the scope. So sorry, Rain, I piggyback. Thank you.
Okay, and then Chris asked, or Helene had a question about how many SBPTE licenses are being approved a year. Did you say? I don't know if Leanne or Chelsea, you have that information.
That's only if someone is endorsing to Hawaii, right? From another state that they've been licensed since I was born, which is a long time ago, and they may have only taken the SBPTE and, endorsed to different states. So they have not had an opportunity to actually, or required to take the NCLEX. I don't see that we get a lot of those. They will be a little older like me, but yeah, we don't get a lot of those. I only see them on the endorsement side. But that would be the only other issue. And maybe, we'll check the NLC rules that they're working on. Maybe they might recognize the SBPTE people as well. Somebody said, Rain, for all of the states that adopted the NLC, do we know if they've experienced our list of cons? I don't know. Unless we provide them.
Sorry. I don't know if you guys can hear me.
Yeah, you sound good.
Sorry, volunteering with our friends here at Campbell High School and their health academy. It's wonderful. So my apologies for being late. Yeah, just curious with all of the states, participating in the licensure compact. When I see things about public safety and a lot of the things that could potentially be missed or go wrong, I just wonder if there are those trying to pull out of the compact, or with any buyer's remorse per se when it joining compact because of those reasons. And it'd be interesting to hear what those experiences are from everyone who's been a part of it. So thanks for all your research, Leanne.
No problem, Rain. So, I just want to clarify, a long time ago, a few years ago, when I attended an executive officers forum with all the executive officers from the NCSBN, I was new. I went to this being the only Asian person there. So I got picked on when they were talking about the NLC because it was kind of beginning. And so they asked, so Miss Hawaii, what do you think? And I said, first of all, don't call me Miss Hawaii because I'm not Miss Hawaii. And then second of all, if Hawaii should join the compact, I told them there would be a major nursing shortage throughout the United States because everybody would want to come to Hawaii. And they all laughed and thought I was kidding, but I wasn't kidding. if you look at the states that have joined the compact, a lot of them for different reasons, right? Hawaii's not attached to any other state. So yes, that allows a nurse to freely move from adjoining states, right? Except for Alaska. Look at some of the states that have a nursing shortage. I'm sorry, I don't mean to pick on North and South Dakota, but who wants to go to North and South Dakota during the winter, right? So yes, everyone's experiencing a nursing shortage for different reasons. And to address it, they joined a compact, hoping people will be able to go there freely and practice if they so wish to do so. You know, who doesn't want to come to Hawaii? Besides the cost of living, who doesn't want to come to Hawaii, practice for a little while, and then move on, right? So that's the other thing we have to, yes, we'll probably get a lot of people coming here. People will be so overjoyed. I can just go to Hawaii now with my multi-state license. Yep, of course they're going to come here. It's just, can we work out the concerns that are being raised, right? And make sure they're safe to come here and practice.
All right, and we have 3 more minutes for questions for this section, and then we'll be moving on. And BJ, your hand is up.
Yeah, so I go back to when I saw the numbers when I first came to Hawaii about the number of nurses that have a Hawaii license that don't work here, or rather live out of state. I guess we don't know too much more about them, you know. So I hear what you're saying, Leanne, but I wonder, why aren't those people that are licensed here living out of state? Why aren't they here? You know, and are they part of the people that could be working here, kind of thing?
Okay, so I can tell you, a few years ago, Hawaii, you know, we had one clerk for exam and one clerk for endorsement, and that's all we had for nursing. And then we started getting thousands and thousands of applications from Florida. Those people were trying to take the exam. So you don't have to live here, obviously, to apply, right? So those people were Florida. So of course, everyone knows about the Operation Nightingale, about the fraudulent transcripts that are now surfacing from Florida schools, right? So we're having to deal with that as well. But so these schools were graduating people that may or may not be qualified. These people were trying to take the NCLEX exam. Florida said, you fail 3 times, you have to take a remedial course. So then now these people who had failed 2 times are trying to look for another state that didn't have a requirement. We were getting tons and tons of applicants. And that's why we had to start adding office assistants to help with the NCLEX, okay, exam applicants. Some of the other office assistants were helping to process these applications. So I think if you look at that latest GEO report, and we're still trying to work on getting a more updated GEO report from September of last year. But yes, those mainland, a majority of them were probably exam applicants. That's why that number is so big. And then you have your travel nurses, obviously, who applied for a permanent license. But I would bet that a majority of those numbers who indicate a mainland address is for those exam applicants. So they get their license, they pass the exam in Hawaii. Unfortunately, we issue a license, and then they just endorse it to another state.
Got it. Thank you, Leanne.
Okay, sure.
And I just put in comments the GEO reports from September 14th, 2023 that Leanne was mentioning.
Oh, it's 2023 now?
Yeah, it got updated last Friday, and we have, I won't know at the end of the meeting, but we also have our workforce supply survey tables up. So we'll give you some new data presents at the end of this meeting. All right, at this time, thank you so much, Leanne. And Chelsea, I know you worked hard on the presentation as well. So thank you so much for providing the information that you did during this meeting. I think it was very helpful. We're going to move on to our next section, which is a panel with our representatives from the Hawaii Association of Health Plans. And so recognizing that we do have the insurance companies or the Hawaii Association of Health Plans, as a working group member, it's important. We have had every other type of organization present on the agenda at this point in time. And we asked, we initially asked as an employer of nurses, and we got that perspective at the first meeting. What is your interest? And HMSA provided that information. This is a different perspective. And the question is, as a health plan, what is your interest in the nurse license compact? And so if you can, and we provided some prompt questions. So if you can talk to those questions as a health plan, what your interest in the nurse license compact, how it may benefit you, how you're engaging in the state in terms of supporting recruitment and retention of nurses and or innovations, that I think that would be helpful for the working group members. I do want to note that our first panelist is not Jonathan Ching. I don't know if you have noticed that this person looks different because he is different. So Rain is our first person from Kaiser Permanente, and then we have Dawn from Hawaii Medical Service Association, and then Paula from Aloha Care. So if you can each provide about 10 minutes of comments. If you use less time, we can have more time for dialogue. So don't feel like you need to fill that whole space if you don't have it, but if you do, we welcome you. And at this point in time, Rain, I'm handing the mic to you.
Sure. Yeah. No, thanks so much, Laura. And I think a lot of this has been said already, but as a health plan, I think for us, being a nationwide organization, it's how do we share best practices and continue to support each other through, whether it's a pandemic or a lot of these disasters where, thank goodness, we've had to depend on governor's proclamations and a lot of things in order to bridge a lot of the pukas and resource needs that we've had throughout those times. And with the looming workforce shortages that we're seeing, the question for us is, where are our experienced workforce in the organizations, and how do we tap into those experiences, whether it's remotely, in person, et cetera, in order to continue to grow and build pipelines, knowing that we don't have a lot of experience on the islands yet, as we now see more and more new grads and new students coming out of school into the workforce. And thanks to programs like the Hawaii State Center for Nursing, we've been able to retain a lot and prevent them from leaving for the mainland. But, with our organization, a lot of the questions between specialty care, the use of technology, even just learning from others who are ahead of us in terms of whether it's technology or innovations, how we can bring them and have them support us here on island, and making that as seamless as possible. And then with training programs, we're only continuing to build more of the training programs. Unfortunately, a lot in terms of training programs in niche specialties like wound care, et cetera, are on the mainland. And so again, for us, is how do we bridge those gaps and build those bridges so that we can assure that we have the right training programs, the right preceptorship, mentorship, and folks who can come physically. And a lot of these things are hands-on skills, obviously, and so make it easy for them to be able to do that skill building and mentorship for our workforce of the future. And so I think a lot of that is where we're seeing a huge interest, Laura. And of course, the question for us in terms of the technology is the use of telehealth. And reaching out in terms of when we need that specialty care, short of having someone spend a lot of money in terms of flights, accommodations, are there things that we can plan for in the future to truly leverage telehealth and be licensed and have the license to be able to provide that care virtually as well. So I think in brevity, those are our big interests and questions as to how the compact can benefit or not only our organization but the communities we serve, my friends. So thanks for the time today.
Thank you very much, Rain. I appreciate that. And then next, if I could invite Dawn Karisu to comment on behalf of HMSA.
Thanks, Laura. Good morning, everybody. On behalf of Jen Diesman and HMSA, just sharing some of the things that we're doing as a health plan and our interests, of course, in the nurse licensure compact. So I think let's, if we start at kind of the school level, so high school level and collegiate level partnerships, one of the things that we're doing at the high school level is partnering with the high schools, particularly through health academies, and also through the Chamber of Commerce to support, health careers, health fields, and interest, particularly in the health fields. Hopefully encouraging students, the young people, to consider careers in nursing and other health services. And the other thing that HMSA has at the high school level is our Kaimana Awards and Scholarships, which does encourage students to return to Hawaii, provide scholarships for students to attend college, but also hopefully return to Hawaii in a health-related career. And at the collegiate level, one of the things that we've been doing is providing grant monies, particularly to the UH School of Nursing, right, to support their nurse education programs and innovations, and provide, as we know, they do a really wonderful job of providing our nursing students with real life experiences in our community, and connecting those students with the various communities across our state. And as far as retention, I think one of the things that we continue to do is provide support for things like Hawaii Workforce Funders Collaborative, and we've supported initiatives and policies around, healthcare loan repayment programs, things that would encourage our nurses to both stay here and practice in our state, particularly in our underserved areas. And lastly, I think, for us, when we think about innovative programs, again, that comes through a lot of our educational institutions, particularly, for example, UH School of Nursing. And one of the programs was Hawaii Keiki, right? Hawaii Keiki, Healthy and Ready to Learn, that was creating innovative ideas, that was encouraging our nursing students to continue to think about nursing in innovative ways and practice here in Hawaii. And so for us, I think the Nurse Licensure Compact really just provides an opportunity. We recognize it's not a silver bullet. It's not going to, solve our nursing shortage, but would provide the opportunity for more licensed providers to be able to serve in our state. And then also, like Rain mentioned, through telehealth, provide opportunity for our local nurses potentially to be able to serve communities beyond our islands. And we're always, invested in supporting our community partners and our facilities to ensure that there's a vibrant workforce here to support all of our communities across the state. So that's about it. Thanks, Laura.
Thank you, Dawn. And Paula, last but not least, if you could comment on Aloha Care. Thank you.
Sure. I hope you don't mind. I prepared a short deck. I thought it'd be helpful to have a little bit of a visual. So I'll go ahead and share that with you right now.
Yeah, and it looks good. It's showing up.
Okay, very good. So just to start with, I want to share a little bit about Aloha Care and our perspective on the nurse workforce as an employer and also as a Medicaid health plan for our membership and our efforts through our Imualoa program, which is our community giving program. So a little bit about Aloha Care. We are a provider-founded organization, community health centers back in 1994, founded Aloha Care, and they continue to be a big part of our leadership. The majority of our board members are comprised of CEOs of health centers across the state. So right now we have about over 82,000 members across the different islands. We have staff on all major islands. Our membership is about 50-50 split between keiki and adults. Our membership range from keiki all the way to kupuna. And then as far as where our members get their primary care, it's a similar split. About 50% get their primary care from a community health center and the other half from other community providers. Our approach to healthcare is pretty comprehensive. We try to integrate as much as we can culturally relevant services. So we have our Ke Aloha Mau benefits, which provide coverage for Native Hawaiian healing services. as well as Promise of Hope is a partnership with the Department of Education to help people to get their diploma, high school diploma, if they hadn't had a chance to get that done. So we'll pay for the fees that are required, as well as help them purchase books and supplies. And we also have a network of social service agencies ready for referrals through our Unite Us partnership. So beyond our medical benefits, we have our community investment program, Imualoa, many CBO, community-based organization partnerships, our public policy program, which brings us to the state legislature every session, and integration of social determinants of health. And so for us, when we look at nursing, the nursing profession, the workforce issues, we employ nurses. So that is a really significant effort for us, like all employers who rely on nurses for their expertise. It's a constant effort to recruit and retain. Nurse leaders have a big role for us in our health coordination services, as well as utilization management. We also have nurses in leadership in our quality program, as well as in our performance optimization. So that includes things like training for our clinical staff, modeling out workflows, standing up new programs, as well as folks in administrative and management roles. And then for our members, we're always looking at how do we optimize access to care so that our members have optimal choices in where and how they get their care. And so we have a commitment that we're always striving to meet to improve access to care and help to strengthen the Medicaid program overall. As you know, many of the folks who relied on employer insurance during the pandemic experienced a downturn in their hours. And so as a result, Medicaid enrollment saw a big boom. So over the 3 years of the pandemic, over 100,000 people signed up for Medicaid, in addition to those who already were with the program. So that presented additional challenges, right? We already had pre-pandemic workforce shortages across the state, especially on neighbor islands and rural areas. And so we're always looking for ways to support strategies that optimize our existing workforce, alleviate their burdens on them, help people to practice at the top of their license. And, we want to see that as a way to improve access to care really for all residents in Hawaii. A little bit about our Imualoa program and the way we've been utilizing that program to support healthcare access and workforce initiatives. Imualoa means to go forward in good health and wellness in the Native Hawaiian language. And we issue grants, scholarships, sponsorships, and charitable donations to support health and well-being. The scholarships that we offer are focused on those folks here in Hawaii who are pursuing a health profession. So we have offered this past year 2 $5,000 scholarships for Oahu members. You can be a family member, and then one on each of the islands. And some of the highlights of our grants and other ways we give out money is really, we've issued money to community health centers for recruiting and hiring expenses, including relocation expenses. During the pandemic, there was a need for our outreach workers to help support the clinicians in the clinics, as well as more demand for telehealth. So we were able to offer a couple of grants to support a brand new kiosk in Eva for the Waianae Comp clinic in Eva. As well as to support mobile services, Healthy Mothers, Healthy Babies, both here on Oahu and the Big Island, and also Malama Ikeola, the health center on Maui. They had a outreach effort for houseless population. And as far as education, we're always looking for ways to support continuing education through different conferences and also through Project ECHO. So that kind of brings me to the conclusion of what we're doing. I would add, as far as legislation, we're always interested in discussing opportunities and options for supporting nurses and other healthcare workforce issues here in Hawaii. We were really encouraged the last session to see the number of compact bills that were introduced. It's not the only option. I think I'm glad to hear there is such a robust discussion in this work group, but we're really very encouraged that legislators are interested in hearing about what our options are. So we look forward to more discussion. I see collaboration, and we want to work with you and all our other stakeholders to help improve our healthcare workforce for everyone. Thank you.
Thank you so much, Paula. I'm going to ask a quick question because I didn't hear it, but it has been a topic of conversation throughout these studies. So one of the challenges with the nursing workforce is that when there is short supply and high demand, prices go up, and we know about this nationally, the high cost of travel nurses. We also know that nurses are the second highest paid in the nation in our state. So I just want to ask, from an insurance perspective, if any one of you are able to answer this, how does the cost of nursing care and the need to cover those expenses, is that factoring in to your interest in the Nurse License Compact? And I think that's a relevant question because we have to consider the total costs in our state, not just licensing, but also the cost of employment, which is driven by reimbursement, but also because we are in a nursing workforce shortage, as I mentioned. So, we have supply and demand, but that doesn't one person can have more than one license. So we don't want to confuse those two. So if you could answer that question, anyone, if you're prepared to, or if you can ponder on it, that would be helpful. And yes, Joan, you are correct. We are the second highest paid workforce in the nation, but when you compare it to cost of living, we know that cost of living is a huge challenge in our state, and it does bring Hawaii nurses down to the lowest reimbursed in the nation when you account for that cost of living. So both statements are true. And unfortunately, yours rings a little bit truer when it comes to day to day.
Hey, Laura. Yeah, I think, when we talk about traveler rates, it used to be that when you hired travelers, they were often really experienced clinicians that you were paying for to fill pukas and staffing, et cetera. But nowadays, what we're seeing is a lot of the travelers, and with higher rates that we're seeing, are a year or so out of school, and you're not quite getting the clinical expertise or the experience that we once saw, I think, in the traveler industry. And I think for us, for the costs that whether it's AMN or a lot of traveler companies are able to ask for in terms of their rates, the question for us is, gosh, could we have our own nurses from other states, come in instead, because they're already, they already know the organization. We have, pretty standardized, streamlined workflows and equipment, and a lot of the things to the point of the safety, aspect. We don't have to do much in terms of onboarding or an orientation, because there are already nurses who work within Kaiser, not just in this state. And so definitely, versus paying, really high rates for a traveler who may not have the experience, much less the organizational knowledge, needed, to function, albeit, after a few weeks of onboarding, they can probably get to a point of surviving, their shift. But in terms of the quality of care and the safety issues mentioned earlier, that's, I think, part of the equation that we're looking at as well. So hope that helps.
Yeah, no, thank you. Thank you very much, Rain. And I know you are unique because Kaiser is an employer and an insurance together. So I don't know if Paula or Dawn, from kind of that traditional insurance model, if you have any input to that as well.
Yeah, so Aloha Care is a Medicaid only health plan. So we are a contractor with the Department of Human Services here in Hawaii for our Medicaid program, and then for our Medicare, which is a special Medicare plan. It's just for low income people. You need to be qualified for Medicaid and Medicare in order to get what we offer, which is called a DSNP plan. We contract with CMS. So we're purely a public health insurer. We don't sell our health insurance to employers. So really, when you're talking about costs being driven up for paying nurses, it does create very uncomfortable pressure because you're talking about state and federal taxpayer dollars. You know, we don't go to employers and say, hey, okay, we're going to have to increase your premiums because we need to now pay this you know, highly paid and highly competitive nurse workforce. So, you know, that's and then the other thing to understand is that we contract with basically the people who employ nurses, right? But it does come back to us in that those entities come back to us and say, hey, we need higher reimbursement because we have these higher expenses. So we are, from our position, we want to see solutions, economical solutions, the most economical that we can afford, to providing high quality nursing care in Hawaii. So I don't have any answers for that. And we are kind of a unique animal. Kaiser's their own animal. We are, and HMSA is also. But yeah, we weren't really looking at the compact agreement as a way to negate costs. We weren't seeing it as a solution to bringing the cost of nursing care down. You know, at this point, we're so very concerned with just getting the number of people that we need. That's the foremost concern is, you know, having providers in place that can provide the care that people need. So we really have not calculated into our position any sort of cost issues at this point.
Thank you. That's helpful, Paula. And Dawn, I don't know if you had any comments, and then I see Paige's hand is up.
Yeah, I mean, you know, to build upon what Paula said, I think, you know, our interest in this is really to address the workforce shortage and to ensure that we have quality of care for all of our members and the entire state. One of the things that HMSA truly supports is team-based care, and nurses are an integral part of team-based care. And so, you know, really quality of care for our members, and also just making sure that, like Paula said, we have the people in place to be able to provide that care across the state. So
thank you. Paige?
Yeah, and thank you, Laura, and thank you, Paula and John and Rain. Rain, I let John Ching know that in the future for all meetings, we'll take you instead of him, which I think he appreciated. No one tell John I said that. So I just want to kind of comment a little bit, I think, on what everyone had said, which is that this, I think, in a way, from the provider point of view, right? And we have these difficult conversations, I think, with our insurance companies. We have the difficult conversations with MedQuest. We have these difficult conversations a lot on the federal level also. You know, we talk to our Region 9 CMS folks about a lot of the difficulties with reimbursement and being able to have adequate capacity in our provider workforce. So that's not just RNs, right? That's physicians, but that's also mental health specialists. It's such a wide range. I mean, we're seeing just a shortage everywhere. So I think one of the things I just want to highlight, right, is that it's a part of the solution. But I think separately, right, there are these other really thorny workforce issues that we're trying to catch up on, that we're trying to train our own, right, get a workforce here. But it's going to take some time. And I think that's why we have to look at a lot of different tools. And if I may, you know, this has just been top of mind. And I know, Laura, we emailed about this. You know, this is really top of mind for us at HAH because there's a federal nurse staffing minimum ratio that was proposed. And the estimated impact would be the need for another 100,000 RNs in the country at an additional cost of $9 billion a year. And that's national, right? That's not just in Hawaii. So we're seeing a huge amount of pressure being put just on the nursing homes, right, to hire more providers, to have more capacity. And I know that one of the biggest concerns that our nursing home members have is that you need an RN on staff 24/7. Right now, you have to have someone at the facility for 8 hours, but you can also use LPNs to help meet some of the safe staffing requirements. So I think that that's the type of thing that we're looking at as, gosh, we would rather have someone local. We don't want to pay travelers, but what's going to happen if you can't get an RN, right, 24/7, if you have to fill that particular need, if someone goes out on family leave, right, if someone goes on vacation, right, a well-earned vacation, or just has some kind of unplanned timeout. So I think that that's how we're thinking about it, but also seeing that there's this huge pressure. And then I think that that goes to a separate question too, Laura, I think we've talked about this too, is, how much is the federal government also willing to invest, right? I think the state, and I want to thank the legislators that we have, there's been an incredible amount of investment, but I know we're working really hard also at the federal level to make more of an investment instead of cuts, right? Because Medicare has been cutting home health, they've been cutting the physician fee schedule, they're cutting nursing facilities, and so that's something that we're also trying to do, is fight back on anything that might compromise our ability to pay providers and pay them a fair wage. So I just kind of say that all that, there's so many things that we're working on, that this is one piece. It's not the thing that's going to solve the workforce problem. I think we're all investing in the things that we want to see. But at the end of the day, right, we need providers, right? And if this proposed rule goes through, for example, nursing homes are going to have a huge push for RNs, or they're going to close beds, or they're going to close down. We anticipate that if the proposed rule went through, there's going to be 260 fewer patient beds in our nursing homes every day. And we know what the wait list problems are like in the hospital. So I think that's kind of the immediate need that we're seeing for providers. So thank you for letting me share that. But I just want to also thank the insurance partners, because I think we're trying to work with them too. And I just want to acknowledge that it's very hard for you guys, and it is creating a lot of that tension for us to support the providers. So thanks.
Paige, quickly, for the long-term care, the federal rule, does that require nurses being RNs being physically present, or can there be virtual or telehealth?
That's a great question. I think we'd have to see that in the proposed rule. So right now it's proposed. Right now, I believe that you'd have to be on site. I don't know if they make modifications. I think, Laura, the other thing that we're fighting back on is the fact that you couldn't use an LPN because CMS, and granted, right, I think we have a lot of sort of nurse folks, but LPNs, you can't use LPNs at all. So you can't use LPNs to meet an RN requirement, and you can't use LPNs to meet your CNA requirement. So I think we're also trying to kind of figure out what could work in there, especially for overnight or weekend shifts. So we don't quite know what it's going to look like. And if that's something, if anyone feels moved to submit comments to CMS as they're due November 6th, that could be, I think that's one of the things that's being considered.
Thank you. And then if there's no other questions from anyone else, Mike's hand is up.
Oh, I don't know if you guys can see me and hear me.
Yeah.
I'm with Aloha Care, so I'll work with Paula. Just wanted to add to your point about reimbursements, and obviously we're Medicaid only, and so we're very grateful that the legislature passed legislation to increase the Medicaid reimbursement rates to Medicare levels for certain providers. So obviously that'll help because Medicaid is obviously lower than the Medicare rates, and that will help just provide greater reimbursement and the ability for providers to provide that care. So I don't know if that is really answering your question, but that's something that we're looking forward to, and hopefully it makes a big impact.
Great. Thank you so much, Mike. Do we have any other comments or questions for this panel? All right, we're a little bit ahead. So we are, I'm going to invite Kelsey George from the National Council of State Legislatures to comment. And then we do have a question that we've from Leanne's section that if we have time, we'll answer at the very end. So I just wanted to note that. So Kelsey, thank you so much for being with us. We really appreciate your time and your willingness to sit through this meeting, and also during different time zones. So I would very much appreciate that. And then if I just wanted to let the group know, in particular, when I was looking at information, I found that they had some nice information about COVID and emergency proclamations. And we've heard that from some other boards of nursing. And I thought that they, as kind of like a umbrella, they kind of see the landscape, would have a good opportunity to share more information about that with us. Kelsey, we can now see a screen that says create a PDF, combine files, open files. There you go. Now that looks great.
Back at it. Cool. Great. Well, thank you, Laura, and thank you all for having me here today. As Laura mentioned, my name is Kelsey George, and I'm a policy specialist with the National Conference of State Legislatures. I'm also joined on the line by my colleague, Zach, who also covers workforce topics, more on the employment and labor side. I work in our health program, so I cover all topics relating to health workforce, including licensure and certification requirements. So I'm excited to talk with you all today about some state actions relating to licensure portability across states. So before I jump in, I want to just provide a brief roadmap of the stuff I'm going to cover today. So first, I'm going to briefly introduce the National Conference of State Legislatures, who we serve and what we do, just so you all know who we are. And then I'll go into some state policy actions that we've seen. So I'll touch on some trends we saw during the COVID-19 public health emergency. I'll provide information on interstate compacts, universal licensure, and then I'll close out by touching on some licensure reciprocity and endorsement, as well as temporary licensure actions. And then we'll wrap things up and we'll have some time for Q&A at the end. So the National Conference of State Legislatures, or NCSL, is the bipartisan organization serving state legislators and legislative staff in all 50 states, the territories, and the Commonwealths. We do this in a variety of ways, including tracking legislation, sharing state policy options, hosting meetings on critical policy issues, and providing legislatures with nonpartisan and up-to-date information. I want to pause here to note that NCSL is governed as a bipartisan organization, and NCSL staff, like myself and Zach, are committed to providing objective, fact and evidence-based nonpartisan research and resources. So states have several options, and we've touched on several of them so far even today, to improve licensure portability for healthcare professionals. And some of those include interstate compacts, universal licensure, endorsement and reciprocity, and temporary and expedited licenses. And we'll touch on each of those a little bit more in a moment. But portability policies like these generally assume that workers who are otherwise qualified to practice in one state should have options that facilitate their mobility and the reduced amount of time that it takes for them to obtain licensure in another state. So many of these actions became very common during the COVID-19 public health emergency in order to ease the burden of licensing restrictions for frontline and essential workers. So some of the state actions that we saw during the public health emergency are pictured on the slide here in this lovely red graphic. So first, we saw many states turn to licensure reciprocity and endorsement, or removing barriers for health professionals that are already licensed in other jurisdictions to practice within their borders. Another common trend during COVID-19 included providing temporary and emergency licensure, allowing states to maintain some regulatory review in place for some out-of-state practitioners. And these temporary and emergency licenses allowed health professionals to bypass certain requirements such as residency or paying the usual fees. We also saw states waiving continuing education and licensure renewal requirements for existing licensees. So this lifted some of the regulatory burdens, allowing healthcare professionals to focus on their jobs during this public health emergency, rather than worrying about renewing their credentials per se. So two states that I'm going to highlight implemented these types of policies that I just shared. So through an executive action, the Alabama Board of Medical Examiners granted temporary emergency licenses for physicians, physician assistants, anesthesiologist assistants, and a few other professionals. And this emergency license didn't require a fee, but it was required to be issued within 48 hours of initial application. So you see that quick turnaround on initial on licensing. And Maryland allowed out-of-state health professionals to immediately practice within the state, and they extended any licenses that were due to expire during the state of emergency until at least 30 days after that emergency was lifted. So now I want to move to a few more permanent changes that states have made beyond the public health emergency. And the first of these is interstate compacts. You all are familiar with these, but they allow various health professionals to provide services to individuals in other states, whether that's in person or via telehealth. Compacts become active once a certain number of states enact legislation, or by a certain date, whichever occurs first. After a state joins, the compact is administered by a non-governmental organization, typically a commission, and joining the compact is voluntary for providers. So participating states in the compact maintain authority to monitor health professionals that are practicing within their borders. I know your main focus is the Nurse Licensure Compact, so I wanted to take a moment to highlight it here. So as you can see on the map on the slide, at least 41 states have enacted the Nurse Licensure Compact, and that includes Pennsylvania, Rhode Island, and the Virgin Islands, which have enacted legislation but are not yet active in the compact. And we've touched on this a little bit, but one common question we hear from state legislators and staff is, does it work? And I want to acknowledge first that the outcomes and data relating to interstate compacts broadly is very limited. But there is some. So research suggests that compacts may enhance the workforce landscape, including labor participation, employment levels, hours worked, earnings, and the likelihood of working across states. So research on the Nurse Licensure Compact in particular is greatly mixed, as you can see on the slide here. Some show no impact, some show some impact. But data generally suggests that the number of nurses holding interstate licensure is increasing, and that many use this licensure for travel nursing, as well as telehealth, as you can see on the top of this slide. Travel nurses, as we just touched on, were essential to meet surge workforce needs during the pandemic, but the practice also created unpredictable relocation patterns and new staffing challenges like the increased wages that we just talked about. So I want to note that the research summaries on this slide are very oversimplified, so I would suggest, I'm happy for Laura to share these slides afterwards, but I would suggest going into these studies themselves for more detail. But the most commonly cited study by De Pascal and Strange from 2006, they used data from 1999 and 2000 very early on in the implementation of the Nurse Licensure Compact, and they found no effect on labor market outcomes. More recent studies suggest that nurses are more likely to move to participate in compact states, and that participation in the Nurse Licensure Compact increases nurse mobility. But one study that I want to note, Norris and Nandy from 2022, did not find evidence of increased telemedicine usage within states that were participating. I also want to note, I heard the question earlier on whether other states have experienced these challenges. The Brookings article that I have linked on the bottom of this does touch on some of the same challenges that were discussed from the Board of Nursing, but most of those are reflected as anticipated challenges, and I haven't been able to identify any research on whether those challenges actually came to fruition after joining to this point. So we'll move on to the next bucket of universal licensure. So universal licensure recognition laws gained momentum before the pandemic, and they've since grown into a more significant practice across states. Universal licensure is a form of occupational licensing in which a state establishes a uniform process to grant recognition to health professionals licensed in another state. So this is different from reciprocity, and instead the scope of universal recognition and what's required of applicants still varies from state to state. And though it may reduce time between application and licensure, universal licensure does not result in immediate practice. State licensing boards maintain the ultimate decision-making power on licensing applications. So at least 19 states have enacted universal licensure laws, and the majority of legislation was introduced between 2019 and 2022. So there's a lot of recent action in this area. So the states shown on the slide here, Wyoming enacted universal licensing recognition in 2021. This legislation allows occupational licensing boards to issue a license as long as the applicant remains in good standing and they meet substantially equivalent educational, training, examination, and experience requirements. Vermont passed a universal licensing law in 2022. And the Vermont law singles out specific population groups, including low-income workers, active duty military, military spouses, veterans, and individuals between the ages of 18 and 25. And Virginia is the most recent state to enact a universal licensure provision this year. So instead of a substantial equivalency standard, Virginia requires the license from another state to be a profession or occupation with a similar scope of practice. So the applicant must have held a professional license in another state for at least 3 years. Now, although each of these examples accomplishes the same general objective, they all fall under the category of universal licensure. It's important to recognize the variability of standards between states. And one example that I want to highlight for universal licensure is the Universal Emergency Volunteer Health Practitioners Act. Now, this is model legislation that was developed in 2006 by the Uniform Law Commission. And I want to pause here to note that NCSL doesn't advocate for or against any specific policies, and information on the UAV HPA that I'm going to share. It's just one of many options that we've covered in just a few moments that states may pursue relating to licensure portability. But according to Uniform Law Commission, states enacting this model bill recognize during declared emergency the licensure of physicians and health practitioners in other states if those professionals have registered with a public or private registration system. So this may increase access to care during emergency situations, particularly when licensing boards may be overwhelmed or requests may be non-functioning, depending on the nature of the emergency. And as the map on this slide shows, at least 19 states have adopted UAV HPA legislation. So before I wrap up, I'm going to provide a brief overview of 2 other licensure portability options: reciprocity or endorsement, and temporary licensure. Licensure, reciprocity, or endorsement removes barriers for health professionals that are already licensed in other jurisdictions to practice within another state. And these options are typically not as comprehensive as universal licensure provisions. States often direct their departments of occupational licensing or specific licensing boards to develop by rule their own endorsement policies. So generally, the application process allows the licensing board to check an applicant's credentials and education in whichever state they're already licensed in. This may be a useful option for states when another state isn't a member of a compact or you don't have a reciprocity agreement, and it can also save a lot of time and headache for applicants themselves. So Idaho enacted legislation in 2021 to clarify and expand their endorsement procedures. This bill allowed military members, veterans, and their spouses to apply for licensure by endorsement as well. So the bill allowed licensing authorities to validate the applicant's current valid and unrestricted licensure in another state, district, or territory of the United States, or in any branch of the armed forces or National Guard. And earlier this year, Utah established reciprocity and endorsement measures and joined the Interstate Teacher Mobility Compact and the Physician Assistant Licensure Compact. Now, this piece of legislation on the slide here created a process for agencies that issue some kind of license, permit, or certificate to do so by endorsement. And Utah targeted occupations that require at least 1 year of occupation or 1 year of experience practicing under a license issued by another state before they were eligible for endorsement. So both universal licensure and endorsement legislation can bring concerns about potentially oversimplifying comparisons in training and education requirements between states and occupations. To address this, in 2019, Arkansas clarified that their endorsement process was intended to ensure that an individual may be credentialed to work in Arkansas if they generally demonstrated the skills and ethics required by state law. So this meant that licensing agencies could not simply compare the required hours of training and other qualifications under Arkansas statute with those in another state. And last but not least, temporary licensure. A few states have also enacted legislation creating temporary permits for certain professions, including nurses. So state actions in this area typically allow temporary practice during a declared emergency or under the supervision of another healthcare professional, while a health professional like a nurse is completing requirements for full licensure. So Indiana allows the Board of Nursing to issue a permit to an RN who has applied for license by examination. This permit is valid for 6 months or until the RN's examination results are received. Under a temporary permit, RNs must practice under the supervision of another RN who's fully licensed and use the abbreviation RNG, or Registered Nurse Graduate. New York established temporary authorization to practice as long as the applicant is in good standing in another state or territory, and there's a declared state disaster emergency by executive order. So as our time together today comes to a close, I want to highlight a few resources that you can all visit for additional information. So you'll see several databases and recent publications from NCSL on this slide. Again, I'm very happy for Laura to share these with you all. And we regularly update our resources, and you can learn about newly published resources and content from NCSL by joining our newsletters on our website. So with that, thank you for your time today. My contact information is here if you have follow-up questions after today's meeting, but I'm happy to take any burning questions now.
Thank you so much, Kelsey. I think that was a nice kind of wrap up for today's presentation, actually. So thank you so much for being willing to be the last on our agenda. And then we do have actually a couple, we're still a little bit ahead. So if we have any questions for Kelsey, let's please, you can raise your hand or chime in. Everybody's camera is off now, so now it's hard to see if people have thinking face. So I had one question for you, because I did notice, and it's something that being so remote, it's a factor that we have to consider. And I don't know if you are able to comment on this, so only within your ability or authority. I'm still trying to figure out why so many states used emergency proclamations during the COVID pandemic while also having the nurse license compact. And I'm not quite sure if it's because not all states have joined the nurse license compact and they were trying to make any nurse available to them, to their own state during that point in time, or if there were other factors. And we also heard from Louisiana Board of Nursing that they opted to use both. They had the nurse license compact and they used emergency proclamations. It's very pertinent for our state. We have a lot of natural disasters. We are currently in an emergency proclamation because of the Maui wildfires. So if you have any insight, that would be helpful, I think, for this group in particular.
Yeah, so I can't speculate on why states have chosen one option or another. We generally just look at trends across states and speak to what they've already done. I don't know of any specific examples of states opting for one or the other or using both, and what parts of their decision were. But that might be a great, that might be a great question for the boards of nursing as well, the national organization.
And then JC, I see, not hearing any other questions right now. JC, was your hand up or was that a mistake?
Oh, sorry, I was just going to say, I mean, to your question, it's a great question. And I think, having more tools in an emergency situation is usually, better, especially when you're thinking about the COVID crisis that we all went through. That's probably a policymaker call more than anything. So maybe it's a question Della or Mark or somebody could answer.
And if any of our elected officials do have a comment on that, we'd appreciate it. I've also thought, but I haven't sought this option for our last meeting. I think there is a National Association of Attorney Generals as well, and I think that they might be best equipped to answer that question. It may be something that we have to ask after the point of the study, though, because we'll run out of time for the report, but that doesn't mean we can't continue to learn new information.
I will jump back in just to say that oftentimes the emergency proclamations had slightly different focuses than the nursing licensure compacts. They may have focused on getting students into practice quicker or bringing retirees back into the workforce. So there may have been different goals depending on how the proclamations were written, how the legislation is written.
Thank you. That's helpful. And then just kind of riffing off this thought, because I seem to be having the opportunity to ask all the questions right now. Can I ask Board of Nursing and Rico, does your workload change within your units or divisions when there are emergency proclamations? I think, Rena, you've implied that there are some impacts. So, and I'm trying to think from the workload or how this, how having a compact versus emergency proclamations impacts our state. So kind of from that generality perspective, could you respond?
This is Rena from the Regulated Industries Complaints Office. Thank you so much, Chair Laura, for asking that question, giving us the opportunity to respond. I think the burden of the increased workload is going to be much heavier on Leanne and her crew than any kind of impact on Rico. And what my boss Esther had related during a prior meeting, I think that was sort of like an unexpected and or exceptional situation. But it's hard for me to say going forward. It would depend on what kind of emergency or special situation. So I think I'm more comfortable to let Leanne speak on this issue. Thank you.
Okay. So based on the COVID, everybody was basically, quote, reacting to the situation. It was unprecedented. We didn't know, nobody knew how to address it. We didn't have any, quote, authorization to issue an emergency license or waive any license requirements. So working on language to come up with an emergency proclamation to allow nurses to move more freely, that took a lot of work because we're starting from scratch. We were just, quote, reacting to this pandemic. We couldn't issue licenses for the first 3 months, obviously, because our office was closed. So nothing was getting issued, right? So all of these situations we had to react to. We did what we could. We tried to work on language that would allow, hopefully, people coming in to practice safely in the practice of nursing. But, looking back on that, should we now put in something in the laws that would allow during a, quote, state of emergency, the board can waive certain license requirements and allow people to come in and practice similar to the language that's in the emergency proclamations? Not sure. Should we join the compact? Would that address this? Not sure, especially if people weren't traveling, not even hardly any nurses, although not sure how the FEMA nurses got here, but in that kind of pandemic, it's hard to say if joining the compact would have addressed those issues. We would have to maybe work with the nurses that we have here. So I know some of the emergency proclamations did allow, Kelsey, like you said, if some states had joined the who were already in the compact may have also initiated some emergency proclamation to allow nurses in their state, licensed in their state with an expired license to practice, right? That's what some of the language in our emergency proclamation also allowed for. So I don't know. Did I answer your question? I'm just all over the place. Oh my gosh.
You're adding a lot of thoughts, but they're meaningful thoughts. So thank you.
Okay. But yeah, so, what was your question? What? Oh, workload. Okay.
Yeah, the question was
So,
workload. I think you're trying to think what, the total impacts, and we're focused today on license processing time and for new grads and licensure by endorsement and getting nurses in to the places they need to be. And so you kind of have to think in these levels of abstraction. And I think you've provided a lot of the insight that is required when these instances come to play. So I think you may not have answered it directly, but I think we got a lot of information from you. It wasn't a yes or no, but I think I'm pointing to yes is what
Okay, all
I
right.
ended up saying. And then Chris, I saw you come off or turn your camera on. Do you have a question or comment? Oh, okay. We're just graced with getting to see you in person a little bit. JC?
I was just gonna say, I wanted to say mahalo to Leanne. I know during pandemic, you guys did so much, but thanks for all you just said. I think it was really important, but also, I think you also indicate how important it is to be nimble, especially when it comes to workforce issues and when you're under kind of an emergency landscape. So thanks for kind of underscoring that. I think that was an important point to be made.
Thank you, JC. And then Joan, you've been waiting patiently. I think you might have had some of your questions answered throughout the rest of the presentation, but I wanted to offer the time for you to ask any additional questions if you had them.
Yeah, so, well, I just want to say that, so do we know what the anticipated increase to the local nurses, like the nurses that are going to stay in Hawaii that don't necessarily want the compact? You know, who don't plan to go back, because I mean, I anticipate you're going to have a lot of mobility here that's going to be also in an outflow direction, because it's just going to be like, I'll go take my 2-week or 6-week whatever vacation they have and then go and try and work in another state. But that's, do we know what the cost to the people who, like myself, my husband, much of the people I work with who have families who aren't planning on becoming travel nurses and who don't really want, wouldn't benefit from a compact per se to have a license in multiple states, what that cost would be?
So the question is there an estimated impact to the single state license?
Yeah. Like who, because those are the residents, for sure, the residents of Hawaii, right? Those are the people that are, that we want here. I mean, go ahead, Leanne, sorry.
Okay, so Joan, earlier in my presentation, I did present some concerns by the Board of Nursing or administration. One of them was the negative fiscal impact, the loss of revenue over $1 million, and we'd have to still pay into the commission, the Nurse Licensure Commission, $6,000 annually. So the question is, where would those funds come from? We're gonna have to increase the single state licenses. I know NCSBN, when they did their presentation on the NLC, they said, well, most states just add $100 to the in-state license for the multi-state license. Well, I'm not sure $100 is going to cut it, right?
And $100 would really make me unhappy.
Well, that's only for the multi-state. I don't know how much a single state license is going to cost. And besides that, if we can't maintain our revenue to support the compliance resolution fund fee that basically pays for our employees and investigators at RICO and all of that stuff, then we're going to have to cut positions, which will then now have a negative impact on the processing of regular applications. So it is going to be like some domino effect. We just don't know how much single state licenses or even the multi-state license, how much we're going to charge to make sure that we are self-sufficient.
So I just want to say in regards to, like the nurses who are trying to get more nurses here in Hawaii to work, who, if they had an increase in their licensure fee, they may not say, I raise my hand, I want to have a multi-state compact fee, because they're living in Hawaii, they're not going to use it. Yeah. So we're just like, and I think we're trying to solve a problem that we've identified. But I don't know that this is the best way. This isn't the root. The problem isn't that people can't get a license in Hawaii. That's not why we have a nursing shortage in Hawaii and the world. And we're going to be creating an inflow and an outflow. As easy as it is to come, it's easy to go. So you may have a net zero, or maybe you have a little up, but it may be not worth the cost. And I'm pretty sure if I don't know if it's even $50 that people would be okay, who are not going to want the compact, which is probably going to be the vast majority of the nurses working in Hawaii would not be using a compact, we hope, right? But they're going to have to be paying more money for their license. And I don't know that it's gonna solve whatever problem is we're trying to solve, which I guess is the nursing shortage.
Yeah. And Leanne, can you comment, license fees, the Board of Nursing and RICO fees, that's established in administrative rules, right?
Chapter 53, yes.
Chapter 53. Okay, so in terms of just putting it in everybody's framework, even if you pass the nurse license compact, in order to change the fees, there would still have to be rule change, which, as Leanne mentioned earlier, is a very long process. So I just wanted to kind of draw those other activities that may need to be addressed as well. I've lost track of the hands going up and down, but I think it was Eric and then Paige.
Thanks. My question is for you, Laura. Is it the Center for Nursing's position that the current nursing shortage in Hawaii can be adequately addressed through the recruitment and the training of new nurses in Hawaii solely? Because to me, that's the message that I'm getting from all of the different representatives of nursing. And because of that, it would seem as though basically the tenor is that we shouldn't go with joining the compact. And again, to our the Hawaii Primary Care Association is looking at this issue solely from a health and safety perspective. I mean, basically, we got involved in this issue because we ran into a situation during COVID where there was an acute shortage of nursing, and we were having trouble getting nurses into the state. Okay. It seems as though the issue has developed a lot larger, and that much of the discussion has been on chronic issues concerning nursing, the shortage in nursing, but it could also be applied in all other professions in healthcare. The legislature last year did, they did approve legislation for compact for physicians. And in many respects, it seems as though this is very similar. And so I guess, I pose the question to you. Do you feel from your organization standpoint that this legislation is not necessary and that we can basically address the shortage of nursing solely domestically within our state? Thanks.
Thank you, Eric. And I thank you for asking that question. And I appreciate your kind of the insight into the larger environment. So it's unfortunately, there's not a yes or no answer to that. In terms of our local community, we have far more individuals, Hawaii state residents, who have completed all of their pre-nursing requirements, but there are not enough educational spots in our state. And so far more. We have huge numbers of people who have completed all of their prereqs for nursing. And our problem is that we cannot expand our nursing programs enough because we don't have enough faculty and because we don't have enough clinical sites. We do have enough students.
Right.
So you can absolutely meet or increase the number of nursing graduates in our state if we could fix the faculty and the clinical placement shortages that would allow for the expansion of nursing education. I will say, though, that you never want 100% of your workforce to be new grads. And so you can increase the volume, but you'll always need to have what I like to say is a nice parfait. We don't want all crust. We don't want all whipped cream. We want layers. And so we have to think about that distribution. We're not going to give you a parfait that's all crust. Not good. Also not good in patient care. And so if you just kind of can think about that, we absolutely have people who want to be nurses in our state, but we can't only have new grads. And so we have to continue to think about where we can recruit nurses who have some level of experience. Rain talked today about recruiting nurses or bringing nurses from the mainland hospitals over to help with training. We're doing a lot of training advancements these days to help experienced nurses get specialty training, but then they'd be new to that specialty. So there's a lot of work to work on that parfait and make sure those levels are equal. And at this point in time, we just don't have enough nurses in our state. So even if we used the new grad option, if we use, and we are, I mean, the hospitals are, many people are hiring local new grads. So the pros with the local residents who want to be nurses is that they already live here. So they have already figured out how to live here, right? They don't have to come in and figure out or find housing, particularly in rural communities, neighbor island communities where housing is very sparse. The con is that you can't have only new grads. And so you still, even if you could use the local community who wants to become nurses, you still have to work on those other layers of the parfait. And we just don't have enough of those nurses. So we still have to have some recruitment from out of state. That is a complex statement. And it doesn't really answer the question about the nurse license compact, because again, we have many people who are licensed in Hawaii. We just don't have enough people who are in Hawaii who are nurses. And they're really two different questions, and you can't really answer one hoping that the other one gets answered, you know, on its behalf. I think, Joan, I want to go on to other questions, if that's okay. Paige, your hand was up, and then Chris, because we're a little bit over time, but.
Yeah. Oh, sorry. And thanks, Laura. And just to go over time, you're reminding me of I worked with someone who only ate the chantilly off the top of Cocoa Puffs from Luliha, and that was my favorite person because I always wanted to eat the bottom Cocoa Puff, and so this is what I thought of. We need both of us to share a Cocoa Puff. So I think two questions I have, and they're related, is one, know that there was a survey that Carrie presented on, and I can't find it. So I don't know if you could send it out again as part of the material. So sorry, my inbox is, I don't know all the words to look for. But I think that the only other thing I was going to say, and just kind of, I think, trying to sort of validate, I think what Joan was saying was that, you know, it might help. I think there was some discussion about potentially having another survey that might be more wide in its applicability. So maybe that's just something to look at. Because I think, Joan, you know, I think what you're saying is correct. I think, you know, we want to make sure that we're looking at what the applicability is, and looking at other states, and looking at the interest of nurses who are already working or new grads to applying for the multi-state license. And I think one of the things maybe we do also have to talk about is, I think now previously we've discussed meeting the fiscal gap by just an increased fee or having maybe an increased fee for multi-state license, but I'm not sure. Oh, thank you. That we've talked about any increase in fee for the single state license. So I think, you know, that's just something, if we do need to talk about, we should, because I'm not sure that was raised previously. So I think that's just, you know, we want to make sure that we talk about that, because I don't know that we've ever talked about increasing the single state licensure fee. But I think just kind of understanding all of that more will be helpful, because I think, you know, some folks were interested in having a multi-state license. But if that's something we need to get more data on, I think there was interest in the last meeting and trying to get more data on that.
I just have to say, sorry, Laura. The people who are interested in a multi-state license fee are interested because they want to go. The ones that live in Hawaii, right? They want a multi-state because they've gone, oh, that'd be great. I can go and travel and work in another state. So maybe that making it easier on them.
I hear that. I think we've heard some different perspectives from some other nurses. And so I think that's why maybe getting more data might be helpful.
And I think, and actually, Paige, I think our data is probably as good as we'll get for, you know, so I just want to say, we will not be able to meet the deadline to submit our report if we open up a new survey, but we got about 500 responses. If you look at the national, like the American Community Survey, they're using a smaller sample and representing all of Hawaii off a smaller sample. And so I think we actually got a good sample. And if the meeting was either meeting 5 or meeting 6, when you go to the link, all of the resources are there. Chris, you had your hand up, but now your hand is down.
I just want to be respectful of everyone's time because I know we're at time, but I really appreciated Eric's question and just wanted to reiterate, we are committed to the new grads and bringing as many in as we can. We hired more this year than we've ever hired, and we just got our new grad residency program accredited, which I'm pretty excited about, first in Hawaii. But really, on the units for safety wise, we can't just have new grads. It's really on the side of having almost 2 new grads right now. There's just a lot of green and new staff in general. So we just have to be cognizant of the fact that we have to have some experienced nurses out there as well. Again, they're coming in from a time that there was very little experience, clinical experience, because they came through at a time of COVID. So just really trying to make sure that we have the right staff mix, experience mix on the units to look after our patients and to be safe in general. So just open to opportunities to be able to collaborate around that in general. Thank you.
All right, well, we are at time. I think this has been, for me, a very helpful meeting, and there is a little bit of an overarching, there's a lot of kind of wrapping up of thoughts. So I want to recognize that. And if you guys can hang on with me for just a moment, I'm going to quickly summarize a number of the findings. So that going through the minutes, and this is kind of where we've been hearing things so far. I don't have the conversations today summarized, so please excuse that, but we are all here. So quickly, we have 16,450 RNs who live in Hawaii and 13,157 RNs who live in the contiguous United States with a Hawaii license. And about 7,000 of those have a multi-state license. So we can imagine if they wanted to, if we joined the Nurse License Compact, we wouldn't, there's some exchange there. In terms of sources of recruitment, employers are hiring new grad nurses, in-state recruitment, they're trying to find whatever they can, interstate recruitment from state to state, and even some international nurses. A change in license type from single state, which is our only option right now, to a multi-state is likely to have negligible impact on Hawaii, given the current number of out-of-state nurses with an active license in Hawaii. And actually, Kelsey provided some interesting information that further validates that today. Most of those articles we have read, but a few we haven't, and so I will send those out so everybody can review them. Challenges with nursing recruitment by employers. The nation and the world is in a nursing workforce shortage, and so the availability of nurses is slim on each island, nationally and internationally. Delays in licensure can lead to failed recruitment, and there are those online application processes that the Board of Nursing is working on. With nurses, local nurses indicate that they have interest in a multi-state license, and that's the survey that Paige was referencing, particularly for out-of-state travel opportunities and out-of-state teaching. About half of whom may opt for a multi-state license would use it to depart the state, is what the nursing survey findings found. There is nearly an 11% increase in nurses' mobility within the compact states. Research suggests that nurses in the compact decrease wages and the probability of employment, while increasing time that registered nurses spend unemployed. The Nurse License Compact significantly increased whether an individual works in or moved to a compact state, and increased enrollment in graduate level education, which is an interesting finding. That was from Marcus and Shakya, those findings. The licensing options, we have licensure by examination, which is largely for new grads. Licensure by endorsement, which is that from state to state, if I have a license in Hawaii and I can apply to Ohio. Temporary permits, which Leanne provided updates, which on the effort to reinstate temporary permits for nurses with an active license and good standing from another state. And no temporary permits have been issued since the start of the COVID pandemic, which is the second quarter of 2020. The emergency proclamations can be used for emergency purposes. The result is authorization for nurses to work without a Hawaii license. And this strategy also creates lost nursing registry information. So it's hard, particularly for RICO and Board of Nursing, to go find these people. It's a different kind of information that we have on them. And the compact improves timeliness of authorization to practice as a nurse. This strategy also creates a loss to nursing registry information. We do generally have good alignment with the 11 uniform license requirements. It's unclear if the areas need to be in rule or practice, or if they actually have to be codified in law. So in some cases we have administrative rules, or the Board of Nursing is doing it, but does the nurse license compact require that they have like a law that they can refer to? So that's clarification that we can seek. The registry of nurses, so there's the repository of known nurses in state would be fundamentally changed. Reporting of employed nurses using a multi-state license is required for employers in some states, and it's unclear how that work in Hawaii, if opted for, would kind of roll out. Employers can review nurses that they are employing using NurseSys. And in general, we've learned from NCSBN, but not many employers have registered to do this, but it's because it's not really practical in our state because everyone has a license. From a regulatory investigation perspective, investigating nurses who are not registered with the Board of Nursing is extremely challenging, and ensuring due process requires considerably more resources, which leads to delays in determinations of the investigation. For workforce research and data, the Nurse License Compact results in undercounting of available nursing workforce by license counts, and the loss of ability to assess the number of nurses who engage in patient care in each state. Maintaining the workforce supply research efforts by the Center for Nursing is more critical than losing the access to data, which tends to be pretty negligible. About travel nurses, NurseSys and e-Notify would result in the loss of a significant amount of data, including well-being, demographic, island, and education data that is uniquely curated for Hawaii. And the workforce data access does not have great importance. Sorry, that's a typo. The workforce data access is not as important as having the information, the registry information for RICO. And so what I'm saying is the loss that the Center for Nursing could handle is a completely different construct than like how other organizations or departments use data. So what may be negligible to us may not be negligible to other organizations or departments. From an education perspective, the multi-state license supports online education and private education providers by enabling out-of-state nurses to teach in Hawaii. And it may benefit new graduates who have more options to work if their license permits them to work in other jurisdictions. And then from the costs, which we had some conversations about today as well as previously, there would be revenue losses to RICO, the Board of Nursing, and the Center for Nursing. And it would be from the out-of-state nurses with a Hawaii license or likely be from out-of-state nurses with a Hawaii license who live in nurse license compact member states. Investigations by RICO staff of multi-state license holding nurses will take considerably more resources, but are not funded by out-of-state multi-state license holders, and the nurse license compact requires a fee as well as designated staff to administer the program locally. The change in revenue does not equal the change in access to nurses. Many out-of-state nurses who have a Hawaii license already have a multi-state license, so they're already available to us. And the greatest impact would likely be license fee changes, not the availability of nurses. It might also be the timeliness. So we do see loss of successful recruitments because of that, the amount of time. And then travel nursing costs remain higher than local nurse salaries. So ensuring full nursing coverage in Hawaii healthcare settings is non-negotiable. And therefore all workforce streams, local travel, out-of-state, permanent recruitment are all necessary to explore. So those are kind of the findings that we've heard throughout each of the meetings. I wanted to summarize them. It's a lot of information. Eric, you are asking what's the position of the center. Trying to maintain the objective approach for this workforce study. I think it's important for us to hear all of the information before we make a decision, but I don't think that there is a smoking bullet here. I think this is very, very complex, and essentially our whole nation, our whole world doesn't have enough nurses. So this is a solution, but there are a lot of other competing and informing factors that we have to take into consideration as well. So I know that was a lot of information, but I wanted to summarize that because our next meeting is our last meeting, and we'll have some opportunities to ask NCSBN as well as DCCA, but we really have to be thinking about how we're concluding our thoughts and preparing this information to submit. So with that, if you have any other comments or questions, I want to open that time, but I also recognize that we are over time, and so I also respect if people need to log off. All righty, well, hearing none, I hope you guys have a good week, and we will see you in 2 weeks on Tuesday.
Thank you.